This is your central venous access device lab. You'll be reviewing this PowerPoint prior to lab, and then you will get hands-on practice within the lab setting. Please keep in mind that CVAD and CVC are used interchangeably among various institutions and in your own textbook. This is just a brief overview of what's going to be discussed in this presentation. Keep in mind that the NPSG stands for the National Client Safety Goal. And these are the guidelines used to prevent infection of the blood from central lines. There's a bundle of nursing interventions to prevent the risk of a central line associated bloodstream infection, also known as CLABI, C-L-A-B-I. This is just information about what's going to be discussed in the TPN section. You'll learn the 3 specific objectives of TPN. You will be managing TPN in the client setting, and you're expected to use this information to keep your client on TPN from harm. This is just a brief overview of peripheral IV lines. Remember that peripheral IV lines are for short-term use. They're usually in place for a very short period of time, normally within a hospital stay or when needed. Check the protocol of your facility. But usually IV lines are changed every 72 to 96 hours. However, some facilities have started to move towards policies where you would change them once they aren't working anymore or look to be damaged, infected, and all of that stuff. So if you have an IV that looks infected, looks like it has infiltrated, you would automatically change that even if the 72 or 96 hours hasn't come up yet. Keep in mind with your cannula catheter that it can range from 3/8 of an inch to 1.5 inches long. Sometimes can be a little bit different if it's inserted by a peripheral IV team or using an ultrasound guided. You want to flush with 1 to 5 mLs of normal saline before and after use of IV fluids when it's not continuously infusing. The gauge of the IV is normally associated with the color. And just keep in mind, the smaller the gauge, the larger the diameter. So a 16 gauge IV has a larger diameter than a 22 gauge IV. On this slide, you'll find a midline catheter. It is a type of peripheral line. Keep a note that this is not a central line. This type of vascular access device should be indicated on the dressing or in the electronic health record so that other nurses, people that would access this device, understand that it is a peripheral line and not a central line. It is inserted into your antecubital, so into the soft part in your elbow, your inner elbow area. Can be left in for 1 to 4 weeks. And again, since it does look similar to a PICC line, you want to make sure that it's somewhere noted that it is a midline catheter. This picture is the central venous catheter non-tunnel type. As you can see, it can be inserted in the subclavian jugular or femoral vein as then advanced to the superior vena cava. It is placed by the MD at the bedside or in vascular radiology. We'll discuss that on a further slide. The tip then resides in the superior vena cava. The line is sutured in place at 3 points, and you need a chest x-ray post-placement to confirm the tip location before using. You can have multiple lumens, single, double, or triple lumen. It remains inserted for up to 6 weeks or more. And you want to make sure this is very important to know, a 10 ml syringe, no smaller ever, to flush. The reason being, if you use a smaller syringe, the excess pressure of the smaller diameter syringe can cause the catheter to rupture. You also want to make sure that you know what your facility uses to flush central venous lines. Some hospitals use saline only, some use saline followed by diluted heparin, but you always want to make sure you're using a 10 ml syringe. You want to always flush immediately after an infusion. An empty fluid container bag lacks the pressure and the blood can backflow into the lumen, causing an occlusion. Prior to inserting any syringe into the end cap, we should always scrub the hub. With a central access device, you are always going to use some type of chlorhexidine swab. They vary depending on facility. You want to scrub vigorously for 15 seconds and then allow to dry for 15 seconds. Check for blood return to ensure that the line is functioning. The way you do this is you're always going to use to flush the catheter the push stop technique or the pulse flush. So we'll show you this in lab, but instead of flushing the full 10 mLs of whatever solution in, you're going to flush a couple mLs, stop, flush a couple mLs, stop, flush a couple mLs, stop. It's the push stop method. Clamp as infusing the last ml of solution. This prevents negative pressure, which can draw blood into the catheter and then sit there until they use it the next time. So when you're using that push flush method, when you get to the last ml is when you want to clamp it. The slider clamp must always be shut before removing the syringe. The caps at the end of the catheters are designed to prevent air from entering or blood from exiting the catheter, but the slider clamp is also another precaution to prevent air from entering the line. Not all catheters have clamps. Some have internal valves. For valved catheters, you'll need to use a positive pressure disconnect when flushing, leaving half to a full ml of saline in the syringe. The nurse should always check the caps at the end of the catheter tubing to make sure they're tight. Caps are changed when the dressings are changed. Beware that the subclavian site has a lower risk of infection than the jugular vein or the femoral vein. So why could this be? So if you think of where the femoral vein is, or the jugular vein, for the femoral vein, you can be contaminated due to multiple things, just the location. But it also can be displaced due to the movement of the area. Moisture can affect the dressing adherence, and you can have bacterial growth because it's so moist there. You want to make sure that transparent dressings are usually changed once a week. PRN is needed, and every 2 days for a gauze dressing, but it's very unusual to use or see a gauze dressing. Most facilities will have some type of dressing change day when it comes to central lines. So I know Ellis, they like to change their dressings on Wednesdays. So if somebody has a catheter, a central venous catheter, you would change their dressing on Wednesday or PRN as needed if it's sooner than that. I want you to review the advantages of having a central line that are listed here. Some of the things that we've already come across is that central lines can be left in long term. Central veins are accessible even if the client is experiencing severe fluid depletion. So if a patient is severely dehydrated, it's easier to access their central line central veins than it is to access a peripheral vein. Phlebitis and infiltration are less likely. You can use it to draw blood. So if you have a patient that's getting frequent blood draws, it's pretty easy to draw off a central line where a peripheral line may not give you blood return. And then some lanes can be used to measure central venous pressure. So you may need this on a patient who may be unstable. When discussing peripherally inserted central catheters, you'll hear us refer to them as PICC lines. They also can be single, double, or triple lumen lines. They can be used for months, often at home. The PICC line does not need replacing unless the site appears infected or the catheter is no longer patent. Most facilities have signs over the bed alerting staff that there are arm precautions, or a client wears a limb alert bracelet to keep you from doing anything on that side that has a PICC line, including taking a blood pressure. Same as the central lines, you always want to use a 10 ml syringe to flush, no smaller ever. And then PICC lines are often not sutured, but require a supportive device, a stat lock. So you'll see they'll come with Foley catheters too, very similar. That just keeps it inserted more securely. Here's an example of a tunneled central venous catheter. They're inserted surgically and threaded under the skin to the subclavian vein and then advanced to the superior vena cava. They again can be single, double, or triple lumen, can be used 1 year or longer. There's a decreased risk of infection because the catheter is tunneled under the skin before it enters the vein, which decreases the chance of bacteria on the skin reaching the bloodstream. Again, use a 10 ml syringe to flush, no smaller ever. Change dressings weekly until healed, then follow organizational policy for dressing change times. Examples include the Hickman, the Grosjean, and the Permacath. Implanted ports are a type of central venous catheter that is used long-term, placed by surgeons, intended for a long-term use. Most of the times you'll see these on patients that have maybe Crohn's disease that need chronic infusions, or if you have a patient who's getting chemotherapy regularly. So those long-term uses are going to have the port inserted into the subcutaneous pocket and in the anterior chest or forearm, where the catheter then enters the internal jugular vein. You will use a special non-coring needle, and basically what the non-coring needle does is when you are puncture at a 90-degree angle into the port, it will actually spread the rubberized area from the septum rather than core out or remove a small chunk of it from the middle of the bevel. And that allows these ports to be accessed multiple times, hundreds of times. You want to make sure you're always using a 10 ml size syringe, no smaller ever, to flush it. And then no blood pressure checks or blood draws on the side where the port is inserted. And a lot of times these patients are very good at telling you where they have a port because you may only just see the scar. Or there's a sign that's on the bedside that they have a port and not to access a certain side. Implanted ports are a type of central venous catheter that is used long-term, placed by surgeons, intended for a long-term use. Most of the times you'll see these on patients that have maybe Crohn's disease that need chronic infusions, or if you have a patient who's getting chemotherapy regularly. So those long-term uses are going to have the port inserted into the subcutaneous pocket and in the anterior chest or forearm, where the catheter then enters the internal jugular vein. You will use a special non-coring needle, and basically what the non-coring needle does is when you are puncture at a 90-degree angle into the port, it will actually spread the rubberized area from the septum rather than core out or remove a small chunk of it from the middle of the bevel. And that allows these ports to be accessed multiple times, hundreds of times. You want to make sure you're always using a 10 ml size syringe, no smaller ever, to flush it. And then no blood pressure checks or blood draws on the side where the port is inserted. And a lot of times these patients are very good at telling you where they have a port because you may only just see the scar. Or there's a sign that's on the bedside that they have a port and not to access a certain side. When assisting with insertion of central venous catheters, there's a couple key things to remember. The client should be supine or Trendelenburg to dilate the neck vessels. Client may be asked to do the Valsalva maneuver during insertion. So just think, what are some of the reasons why they may be asked to do this Valsalva maneuver? What it does is it produces a positive phase in the central venous pressure, which decreases the chance of air entering circulation. When you're asked to teach somebody how to do the Valsalva maneuver, you want to instruct the client to take a deep breath, hold it, and bear down with their mouth closed. It's the same as straining to have a bowel movement. You must turn the client's head away from the site of insertion and remain still or wear a mask. Why would you do this? It increases the visualization of the site for the person inserting the central venous catheter. It also maximizes the accuracy of placement on the catheter and ensures surgical aseptic technique because the patient's not breathing on it or moving. It is a sterile procedure. Accurate placement of the catheter must be confirmed by X-ray or fluoroscopy before use. So no IV fluids, meds, anything can be instilled until placement is confirmed. And it may be required to obtain an X-ray for placement if the client arrives from another facility with the central line in place. You want to remember, non-tunneled central venous access devices have the highest rate of infection of all types. Aseptic technique must be used. Changing the dressing of a central venous access device will be covered in the complex dressing college lab that's going to be later on in the semester. There can be complications of central venous catheters. It is your responsibility as the nurse to evaluate and assess your client. So some of the things that can happen, a pneumothorax. That's when the lung pleura is punctured during insertion. You can have infection or sepsis. So what signs and symptoms might you see? You want to watch for infection, redness, drainage at the site. Provider must use strict sterile technique during insertion. The nurse must change the IV solution, tubing, dressing, catheter caps per protocol as delineated by the infection control at your facility. You want to use evidence-based practice when you're bundling your interventions, including hand hygiene, clean gloves, scrubbing the hub, and accessing the site and the line. Some third-party insurance companies will not cover the cost of a catheter-related bloodstream infection, CRBSI. You can have a thrombophlebitis, which is your nurse's responsibility is to assess the insertion site and use filters in the IV tubing when indicated. The catheter may migrate or become dislodged, which could result in neck swelling or pain, bleeding at the site or within the line, heart palpitations, or a gurgling noise. With the catheter migration, it can migrate from the superior vena cava to the internal jugular vein, axillary vein, or right atrium. You may see swelling in the subacute tissue, the clavicle area. The patient may complain of neck or ear pain. You could also have occlusion of the line. You may discover this when attempting to flush the line and you're unable to. You can prevent an occlusion by adhering to the flushing protocol, being sure the IV meds given are compatible with the IV solution infusing. Do not force flushes through the catheter. Meds can be instilled in the catheter to dissolve the clot. You would need a doctor's order for that. The current most effective medication is Altipase. It is a tissue plasminogen activator, aka TPA. The dose is 2 milligrams per 2 mLs instilled times 2 hours. You can also have hemorrhage. This can occur when the caps are removed and an unclamped line. The CVCs are placed in major blood vessels, therefore the patient could bleed out. It's a very real danger, and the nurse must use preventative interventions, including keeping the caps tight, always checking the caps, making sure the clamps are closed when the line's not in use. You can have pinch-off syndrome, which is compressed between the first rib and the clavicle. When you have pinched-off syndrome, have the client shrug shoulders or raise arms if unable to flush. Air embolism. When air enters the veins and gets into the right ventricle, it lodges against the pulmonary valve and blocks the flow of the blood from the ventricle into the pulmonary arteries. This can occur during insertion or when caps on tubing are changed. Signs and symptoms: dyspnea, tachypnea, lightheadedness, tachycardia, hypotension, confusion, cyanosis, chest, shoulder, or low back pain. You would treat an air embolism by positioning the patient on the left side, placing the head in the lowest position, Trendelenburg, so air will rise above the pulmonary artery. Make sure you may notify the provider, and they may also be placed on oxygen. TPN stands for Total Parenteral Nutrition, and it is a hypertonic solution providing nutrients via the IV route. Enteral feeding should be attempted if medically indicated prior to initiating TPN, as it assists with maintaining the mucosal integrity of the GI tract, and it improves immune function and has fewer complications. However, some indications for using TPN could be that oral intake does not maintain an anabolic state. For example, clients with burns, HIV, or cancer that may need extra calories, so their oral intake is just not enough. They're unable to ingest food. For example, paralytic ileus prevents food from moving through the GI tract. Crohn's disease prevents absorption of nutrients. The patient is unable or unwilling to take nutrients via the GI tract. Anorexia nervosa, post-op client who does not feel like eating. The GI tract must heal if following a GI surgery. You have prolonged NPO status after surgery. So if a patient is going to be on NPO status for a long time after surgery, they may receive TPN. negative nitrogen balance. The decline is NPO greater than 7 to 10 days. 1 liter of 5% dextrose only provides around 200 calories, so they may need more than just IV fluids. There are some complications associated with using TPN. Infection, in addition to the complications of a central line, TPN is a good medium for growth of pathogens such as bacteria or fungus due to its high dextrose and fat content. Infection can be local at the IV insertion site, where you'll have or generalized, where you have a fever, increased white blood cell count, and tachycardia, etc. The fat globules cannot pass through a 0.22 micron filter. So if the lipids are administered and there is no filter available, they must be connected below the filter. You can check in your trace book for filter sizes. Hyperglycemia is going to be when you have a high percentage of dextrose in the TPN. The high percentage of dextrose may need to be adjusted or regular insulin added. A gradual increase in mLs per hour of TPN provides the body time to increase its insulin production to manage increased dextrose in a TPN solution, thus preventing hyperglycemia. So if you have a patient who is receiving TPN, you may start it off slower until you and slowly start to increase it, which allows your body to adjust to the high amount of sugar rather than just giving them a high amount of sugar to start. Hypoglycemia, when the TPN bag is empty and now there's a new TPN bag that's not available. This can happen when it takes a while to come up from pharmacy. The nurse gets busy somewhere else. So if this happens, you want to hang 10% dextrose while you're waiting to hang a new TPN bag. This can also occur if the line occludes and you're waiting for another line to be placed. Slowly decreasing the TPN infusion when discontinuing allows the body time to slowly decrease insulin production, thus preventing hypoglycemia. So the reverse of starting the TPN slowly, we want to end the TPN slowly as well. Blood glucose should be checked every 4 to 6 hours upon initiation of TPN until stable, then should be checked daily. The client may need insulin administered via the sub-Q route or via the TPN solution. Many smart pumps used in the home setting have a function that will automatically titrate the TPN rates up and down at the start of the bag and then at the end of the bag. More TPN complications include fluid and electrolyte imbalances, which is why you check the blood glucose every 4 to 6 hours. Also, you want to check the electrolyte levels as ordered and never change the ordered rate. The TPN is a hypertonic solution, so it has a higher osmolality than that of the serum, that of the blood, which could cause fluid to shift by pulling fluid and electrolytes from the intracellular and interstitial spaces into the intravascular compartment. Low potassium hypokalemia can occur. Also, if your TPN is given too fast, hyperosmolar diuresis of the excess sugar that the body's not used to having can occur, causing the excess fluid to be lost. And that's when the body is eliminating the excess sugar, the water's also going with it. So you're trying to get rid of the extra sugar and you're also getting rid of the extra water as well. More TPN complications continued includes incompatibility. It is recommended that nothing is administered in the same line as TPN, and that line is normally identified for everybody accessing the central line, that they know that that's the port that the TPN goes through. Most things are not compatible in solution with TPN. There may be special circumstances, and it should be documented that it was checked with pharmacy that you were able to give something with the TPN through the same line. Here you'll see an example of a TPN label. Keep in mind that this label in the middle is on the next slide so that you can read it a little easier. Dextrose provides carbohydrates and calories for metabolism, which is why you'll see dextrose. Amino acids provide protein for tissue repair. The lipids provide essential fatty acids and calories for metabolism. Also, all calories do not need to come from dextrose. Electrolytes maintain cardiac function, the potassium, fluid balance, the sodium, development of bones, the calcium, etc. Trace elements and vitamins added for their various purposes: wound healing, vitamin C, bone metabolism, vitamin D, clotting, vitamin K, carbohydrate absorption, the B vitamins. You want to compare the label on the bag to the order, so 2 to 3 liters over a 24-hour period. Lipids may be given in a separate IV bag. Just an FYI, lipids do not need IV tubing with a filter, but TPN does. Lipids are connected to the TPN tubing at the Y port closest to the client. So that is it for your central venous catheter and PICC line lab PowerPoint. So when you do come to the lab, you will be rotating through stations for practice with these lines, and we can help answer any additional questions that you may have.